superiorly in the region of the pars flaccida, just above that, the region of the attic. I'm not too sure whether that's just a poor image or
So that's absolutely correct. I'm just going. Absolutely correct, Bouclet. Thank you. So, I mean, what this was just demonstrating is that there's inflammation of the ear canal. And with that in mind, what is your diagnosis?
so I'm concerned about an Otitis externa, but because as well he is a diabetic, then I would be concerned about, I want to make sure it's not malignant otitis externa.
Fantastic, thank you. So indeed, you know, we had a look, and he does have an otitis externa, and the otorrhea then was quite, this progressed, and he now developed a lot of ear discharge, a lot of foul-smelling purulent discharge. And at this point, the question that we then got was that whether we should take a pus swab or not. Certainly when you read around with pus swabs, you don't necessarily need to do it firsthand off the bat. A lot of people recommend it when you have cases that are resistant to usual treatment or cases that are severely immunocompromised. So we didn't really proceed to that initially. And then we put them on normal conventional treatment. And our treatment first was just based on a thorough toilet. And, you know, if you just look at the literature about what a simple toilet can do, you know, once a thorough toilet is performed, evidence shows very little benefit between the various topical agents. And as you can see there, once you add something, and people say almost anything, and that can include antibiotics, steroids, even sometimes antifungals, or a combination of those things, this confers benefit to toilet alone. But really, there was not much benefit of one topical agent over the other agent, provided that you give a nice, decent oral toilet. And also, what I found quite interesting is that the sensitivity of the bacteria to the topical antibiotic does not actually seem to influence the outcome of these patients. That was also quite interesting. I think when we talk about a toilet, a lot of people just imagine it being quite formally under a microscope, but it's important to mention that there are different ways of doing a toilet as well. You know, you can sit down and on a chair, sometimes with a headlight, you can suction or dry mop yourself, or you can create an earwick and instruct the parents or the caregivers of this patient to actually do it at home. So toilet can actually mean different things, that it's not really confined to only a microscope. So just moving on now, is that this patient didn't get better, and this patient started getting severe pain that was really worse at night. It was a deep stabbing pain, and it was quite resistant to usual analgesia. He didn't seek treatment, as I said. He was locked down, and it wasn't able to immediately come to hospital, and then he developed a lateral facial palsy as well. And he eventually came up to us, and when we looked in his ear canal, this is what we saw. Does anybody care to maybe comment on what they see or what really occurs to them when they look at that photograph?
Cool.
I'm just looking at the participants. Maybe can I ask maybe Aisha?
Yeah, so there appears to be either granulation or a polyp in the floor of the ear canal, which is quite medial, so it looks slightly concerning. So I'd want to, do a thorough examination under a microscope, and also take some samples both for microbiology and for histology.
Okay, fantastic. And Aisha, can I ask, would you image this patient right now?
Yeah, so you said he's diabetic, things have progressed, it's been, possibly a few weeks since he first presented. So this patient we would usually admit into hospital. We would image, so he'd have a CT temporal bone. Sometimes if you do them early on, you won't see any problems in the floor, so malignant otitis externa won't show up on the scan, but we would still treat him as a malignant otitis externa regardless of the scan findings. So yeah, he would be admitted for intravenous antibiotics as well.
Okay, fantastic. So I'm just going to take you up on that offer, Aisha, and we did do a CT scan of this patient, and first of all, just looking at that otoscopy, what is your diagnosis?
So I think that's malignant otitis externa.
Okay, and just judging by the information I've given just in the last few slides, why would you say that, just from a history?
He's diabetic.
Yeah, he's diabetic, so he's immunocompromised. The night pain that you mentioned, and also the granulation or the polyp in the floor.
Okay, fantastic. And the ipsilateral facial nerve palsy as well,
Yeah.
that he developed. So that, I think that was quite interesting. And so as you rightly said, is that we did image this patient, and this is what the image looked like. Aisha or anybody else that cares to maybe comment on the CT scan findings?
So if you have a look at the CT axial view on the right side, it appears that the ear canal is filled with debris, also quite edematous. The mastoid air cells are opacified, and there's a lot of irregularity on the posterior wall of the ear canal here in comparison to the left side.
Thank you. Yes, and I think just to highlight, when you look at this scan, I mean, this goes back to the definition of a malignant otitis externa, and really the definition of something like this has to include a radiological or histological evidence of bony involvement, and that's the big differentiation between a sort of a simple otitis externa and then it progressing to necrotizing or a malignant necrotizing otitis externa. As you can see there, almost the whole posterior canal has been eroded with bone. Oh, sorry, the bony erosion has taken place. So it's important to mention that CT scan only detects bony demineralization when up to about 30% has occurred. And that can take months to occur. And a lot of people around the world that maybe in other settings do nuclear imaging. So TC99 is an option that can give you almost 100% sensitivity quite acutely. The radiotracer accumulates in areas of high osteoblastic activity, and that's quite sensitive, but it's actually not very specific because in malignancies, it's also going to be positive, and therefore in those kind of cases, histology is very, very important. The second or the third scan modality that you can also advocate for is gallium. So if you do have the resources for that, that's also an option. And that is an option when you're monitoring treatment, because that accumulates in, the radiotracer accumulates in areas of active inflammation. And as recovery takes place, that uptake reduces. So those are options just, spectrum-wise, depending on what setting you're practicing in. But certainly we were happy with doing a CT scan, looking at what that bony erosion looked like, and then progressing this patient onto treatment. So, so when we talk about benign versus malignant otitis externa, the main thing is that with the benign necrotizing otitis externa, it's just a vascular bone with inflammation, but there's no obvious signs of an infection. And this is really treated quite conservatively. It's largely painless, and it's a chronic inflammation that usually resolves spontaneously or with time conservatively. But with the malignant necrotizing otitis externa, the risk factors are as this patient had. You get severe pain, cranial palsies, Pseudomonas in over 65% of the cases is the organism that is identified, and you actually need to treat this patient quite aggressively. When we talk about workup and differentials for this patient as well, is there anyone that maybe wants to comment, maybe specifically speaking about what we found in the otoscopy and what they would need to exclude in a patient like this? I can open up to any exam candidates nationally or anybody else.
Tasia, for the sake of time, we've only got 5 minutes left for your presentation. So could you perhaps wrap up and then we could perhaps open the floor for discussion?
Sure. So essentially what I was going to bring out is that, we need to actually take histology for what we saw, those granulations that we found in the ear canal. So we need to rule out a malignancy, chronic inflammatory conditions as well, TB as well, especially in settings such as ours. And then we need to think about complications as well. So as I mentioned, this patient already had developed an ipsilateral facial nerve palsy, but really that can progress. The facial nerve is in the vicinity of the external auditory canal. But as the inflammation and the infection progresses through the fissures of Santorini, through the tympanomastoid suture, this goes to the jugular foramen. It can progress up to mastoid, up to petrous apex, and even reach the optic nerve. So all these cranial nerves can actually potentially get involved. And you can also get a septic thrombosis of the sigmoid sinus and the internal jugular vein. So really our management, our core management was good oral toilet, glycemic control, especially in this patient that is a diabetic, that goes hand in hand with infection control. So if your glycemia is not controlled, your infection worsens, and if your infection is not controlled, your sugar worsens. And antibiotics, topical and systemic. And there's a lot of debate about the choice of antibiotics. Or what you use, whether it could be either off the bat ciprofloxacin, and really when you look at the literature that's been presented, the initial treatment being advocated for is ciprofloxacin, 750 milligrams twice daily. That's normal. That's higher than the normal dose that's usually prescribed. The other question that a lot of people have in malignant otitis externa is whether you start these patients on oral treatment first, or whether you can first start on parenteral treatment. And really, if you look at the literature as well, this is not something that's completely agreed upon, but starting off orally is normally what most people do. Some people advocate for starting parentally, and initially, parentally, and that's converted to orally once the inflammatory markers start to decline. The other option that people do is that they only start parenteral treatment, especially with ceftazidime, IV at high doses in Pseudomonas that are resistant to normal treatment like ciprofloxacin. The other thing is about how long do you treat these patients for? This is going to be a long, it's also debated, but a long course of at least about 6 to 8 weeks has been advocated. This can actually progress to months. Some people say as long as you have this modality, as long as the 57 scan is positive. So this was really the case that I wanted to just bring out there. There are a lot of controversies when you talk about imaging or treatment modalities and how long you treat for and what kind of treatment. And it was just to really nudge a discussion on what the different practices are nationally and in Africa. Thank you very much.
Thanks, Tasia. Could we just open up some discussion, perhaps Prof, if you have any comments?
Well, thanks, Tasia. That's a very good overview. Perhaps we can ask Tashneem if she's online, whether she'd like to comment. Yes, Tashneem. Tashneem, you want to comment?
She's not online.
Okay,
I don't think she's online, Prof.
Okay, perhaps ask Prof. Sidat what their practice in Bloemfontein would be.
This was a very good presentation. We basically follow the same protocol as what the SEER outlined. I think the glucose control is a very important aspect of the management, because without that, you're not going to get the infection under control.
Okay, any other comments from elsewhere in South Africa or from elsewhere in Africa?
Prof, this is Sean from Tygerberg. We had a case quite recently and had quite long discussions with microbiology and infectious disease. And what they seem to advocate is using a beta-lactam antibiotic as a first line rather than fluoroquinolone. The argument for that is that in theory, it's bactericidal rather than bacteriostatic, what ciprofloxacin is. Don't know what your thoughts on that are.
Dr. Seer, do you want to comment on that? Did you come across that in your reading?
Yes. So, Sean, I was just reading about different modalities and how you give them. So, the only thing that's actually solid evidence based is starting initially with ciprofloxacin 750 milligrams BD, and that's not only because of the ease of giving it orally, but also because this patient can be discharged quite sooner back to go home. So that is advocated initially, and even in the 8th edition of Scott Brown, that's evidence-based, and they advocate ciprofloxacin. But the ceftazidime, I could see the reviews that I read said that there's weak evidence for starting that initially. And really the only justification of this was that if your ciprofloxacin fails initially, or you get a culture, and that's quite important, getting histology and microscopy and cultures for these specimens, and you get a culture that's resistant to the fluoroquinolone, and then you could be justified giving these patients IV ceftazidime. But otherwise, off the bat, I didn't actually come across something that's evidence-based.
Well, perhaps we can get opinion from Oxford, from Aisha.
We don't usually start with ciprofloxacin. We go straight to intravenous ceftazidime. I think we've just had a massive influx of cases over the past 1 to 2 years, and we're not quite sure why. And we think it could be due to syringing, but it's not uncommon that we have at least 5 patients on our ward of these patients. So we found that if we gave ciprofloxacin, they would still progress to a lot of cranial nerve palsies. So we would give them ceftazidime for 4 to 6 weeks until their pain has settled, and then go on to ciprofloxacin. And usually, again, that's a prolonged period. So again, at least sometimes 6 weeks. And we found that helps. And if we just gave ceftazidime for 2 weeks and then went on to cipro, again, that doesn't seem to control their infection. I don't know if we've got something, it's not resistant, but we don't know why they're not sort of responding to the ciprofloxacin. I'm not sure if you're seeing an influx of cases as well out there. And then obviously, if we're giving such prolonged course of intravenous antibiotics, it does mean a prolonged hospital stay. So what we've done now is we've started to send them home. So they get ambulatory care, they get nurses coming in to give them their antibiotics, and then they come to see us once a week for blood tests and for review of their ear. And then that way we can get them discharged.
Well, it seems like there seems to be some variation in the treatment of these, and it might be good to pull together a study around South Africa because these aren't common cases, and to see what people are doing, and to track what the outcomes of the different treatment modalities have been. So I'll leave that with you.
Absolutely, Prof. I think even if you go through the literature, people say ciprofloxacin, people say any 3rd generation cephalosporin, and some people even say rifampicin. So it's a very varied treatment of what you can use for these kind of patients. But what's very, very important is, first of all, think about where you're going to be treating these patients. So for us to keep a patient in hospital with no really option of having ambulatory care for about 6 to 8 weeks sometimes is not really feasible. So I think it's also a reflection on you being able to discharge this patient on oral ciprofloxacin while keeping a close eye on them. And also, as I said before, it alludes to you having the importance of getting a microscopy and culture on these specimens quite early in your treatment as well.
Okay, Nick, over to you.
Yeah, thanks. There's just one question from Freya ENT. Anecdotally, we don't see more malignant otitis externa than other places, despite a very high HIV prevalence. Any ideas or evidence as to why? Just here.
So I mean, when you talk about immunosuppression, so one of the biggest risk factors for malignant otitis externa is immunosuppression. And certainly if you have well-controlled diabetes or patients with high CD4 counts that are well treated, you don't really expect them necessarily to go on to progress to malignant otitis externa. And that argument can be extrapolated to any other forms of immunosuppression like steroids, chemotherapy, patients with severe anemia, leukemia, patients that are post-renal transplantation on steroids. So I think whatever the condition is, whether it's HIV/AIDS or whether it's diabetes, I think the importance is to get that well controlled. And certainly HIV in Freya, I think your question is maybe some of them are quite well controlled, or maybe they're treated early. I don't know what your thoughts are, maybe on just reverting back the question back to you and what you think, why it's not as prevalent there.
Tasir, can I just add? I think with diabetes, you get dysfunctional neutrophils versus HIV. It affects more your lymphocytes that obviously helps for your resistance against viral infections. So the mechanism of resistance or immunocompromised state is different from HIV compared to something like diabetes. It's the fact that your neutrophils aren't able to function properly because of the hyperglycemic state that you're prone to getting more bacterial infections.
Yeah, thanks, Dr. Pretorius. Thanks, Tasir. I think that's what I was getting at, because when we always talk about this, we talk about immunosuppression. And even in very immunosuppressed HIV patients, we personally haven't seen any otitis externa. So I was wondering if it's more actually about the diabetes, the hyperglycemic state, the neutrophil impairment, and those kinds, rather than general immunosuppression. But I just wanted to know also if anyone had experience in South Africa or any evidence on that. But that's, yeah, I guess that makes sense. Thanks.
I think also just commenting specifically for diabetes, Josh, is they get an end arteritis and they also get coagulopathies. So they get microangiopathies that predispose them to necrosis or ischemic necrosis really of bone. So that's another predisposing factors that I think diabetes would have or diabetics would have rather than HIV positive individuals.
Okay, we're running out of time, so we're going to have to move on to the next presentation. Welcome Sean from Stellenbosch. He's going to give his talk now. Sean, you're welcome to share your screen.
Sorry, just be there for a moment. I'm here again, sorry. Just a bit of technical difficulty. Is that shared?
Yeah, we can see it, thanks.
Okay, so I'll dive right in. The case presentation that I've got today involves a 42-year-old woman who had no previous past medical history. She wasn't on any medication, no significant social history, good performance status. And she presented with a 2-month history of quite a rapidly enlarging left painful facial swelling. She'd also, in the last 2 weeks, developed some facial weakness and asymmetry. She had no prior other skin, eye, scalp, or head and neck lesions or other excisions, no radiotherapy. She had no airway problems, no systemic symptoms that could be elicited, and no generalized symptoms of fever, malaise, or other systemic problems. On examination, she had a left parotid lesion. It was 4 by 5 centimeters. It was firm and mobile. It was predominantly preauricular with an extension down into the neck to level 3. We were unable clinically to get underneath the tumor. It was tender on palpation for her, but it wasn't fluctuant, and there was no erythema, it wasn't warm, and there were no overlying skin changes. On the rest of her examination, the scalp, the external ear canal, the eye were all normal. She had no palpable lymph nodes beyond this mass. There was no medialization of the tonsil. The cranial nerve fallout was, in essence, Hausbachmann 4. And those are the specific branches that had fallout. She had no other cranial nerve fallout, no Horner syndrome. So our initial investigations showed that she was HIV negative. Renal function was normal, and HP close to normal. FNA from peripheral hospital was paucicellular, but indicated a possible pleomorphic adenoma. Perhaps I can ask if anybody's got any suggestions on what to do from here.
Hi, Sean. It's Gerrit here from UCT. I'd be very concerned about the facial nerve palsy, because generally a pleomorphic adenoma shouldn't give a facial nerve palsy. And I think it's important to take malignancy into account, and I think a CT scan from here would be a good first choice investigation. Thanks.
Hi, Sean. This is Devesh from UFS. I also think the other concerning thing is that the history is quite short. And then coupled with the facial nerve, I agree that imaging is probably what you would want to do, and repeat that fine needle maybe, just to have a different, a second opinion. Thank you.
Yeah. Are there any other thoughts, or I'll continue, I think? So for us, obviously, the pain control, and then as you guys have both already alluded to, a contrasted CT scan. At this point, a true cut biopsy was actually undertaken, and I will accept that this is quite controversial. But in the light of what looks clinically like a malignancy and only a pleomorphic adenoma, we felt it's important to try and determine histology. But I would, agree that a second FNA is also a reasonable option. So I wasn't able to upload too many images, but here's just 3. I hope you can all see them. But the first is a coronal view showing a left-sided parotid lesion. You can see that there is a heterogeneous opacification, so there seems to be some central, at least breakdown. One could consider in a pleomorphic adenoma that it might be cystic, but it seems more to be central breakdown and necrosis. The internal jugular vein is abutted by the tumor, but it didn't seem to be invaded. There was some space or a line or margin that you could see between the tumor and the internal jugular vein. The parotid obviously up to skull base, and you can see it's also abutting and decreasing the paraglot or the parapharyngeal fat pad is also compressed, so it seems to be into the deep lobe as well. So in essence, there was central necrosis. There was extension into the deep lobe in the parapharyngeal space. The lesion was up to the styloid process. It was, as I said, up to and onto internal jugular vein. It wasn't encasing the internal carotid. There was no base of skull bone erosion. It wasn't invading the pterygoid plates. And then of note, there were multiple nodes in level 2 and 3, the largest of which was 10.8 millimeters. So the large bore, the true cut biopsy also revealed a pleomorphic adenoma. Any ideas on staging at this point?
Perhaps I can comment. Yeah, I don't believe the true cut biopsy. The history, as Gerrit said, just doesn't fit in with that at all. And I think if they think it's a pleomorphic adenoma, you have to think of a carcinoma ex pleomorphic adenoma as being part of the differential diagnosis here.
Can I ask, Prof, on that note, would it assist you in counseling the patient preoperatively, particularly with regards to the facial nerve and facial nerve management, or would the facial nerve dysfunction pre-op be enough for you to counsel the patient?
Well, the concern always is, with cytology indicating a benign tumor, you don't want to sacrifice the facial nerve at surgery, but looking at the extent of that tumor, it's going to be encasing that facial nerve, I'm sure. The other option, of course, is to do a fine needle aspiration of one of the lymph nodes, because if that's going to show a similar pathology, then you know you're dealing with a malignant tumor.
Okay. Any other comments? Otherwise, I'll carry on. Yep. So clinically, I think we could probably all agree that this is a malignant lesion, even though we didn't have histology to prove it. And there was extra parenchymal spread with a facial nerve involvement. So there's a T4A, and those nodes seem to be involved. So we labeled it an N2B. The patient was then admitted 3 weeks later for surgery. And clinically, there was extension of that lesion in the 3 weeks. There was worsening, firstly, of the facial nerve function. There was now skin involvement, and there was reduced mobility of the mass. So I guess what I want to ask is everybody happy that you would proceed to surgery, or would there be any other plan at this point? Anything else that you'd want to do?
Right, if you'd like me to comment here, I don't think that's an operable tumor at this point, and I would possibly opt for an incision biopsy just to confirm the malignancy, and we probably treat the patient with non-surgically, because I really don't think you get that tumor out.
Okay. So it was deemed to be resectable in quite a young female in our setting. We did go ahead with surgery. I'm not sure if this all shows up, but in terms of managing the primary of the neck, the problems were around obviously your incision. If you're going to do a modified radical neck dissection with the parotidectomy, the hockey stick incision is probably the first choice. Then in terms of identifying that facial nerve, as Prof has alluded to, it's most likely going to be encased, and that's going to be very tricky, and need to potentially have a retrograde approach, if not a cortical mastoidectomy, to identify the facial nerve within the vertical segment. Obviously, with all of these cases that are malignant or potentially malignant, you'd want to use a facial nerve monitor. And then we had to have plastic surgery on standby with a few different options to reconstruct the facial nerve. So at the time of surgery, the periosteum at the base of skull was free. There was no bone erosion. The lesion was onto the styloid process, but it wasn't clinically involved. The accessory nerve was encased, so that was sacrificed. The facial trunk was invaded, as well as the sternocleidomastoid and the posterior digastric. So the surgery pretty much entailed a total parotidectomy, retrograde identification of the facial nerve distal branches, and that was a combination of clinically looking for where we would expect branches to be, and facial nerve monitor and facial twitches, and a type 1 modified radical neck dissection. The major concern was around the skull base, and that's probably what Prof. Fagan, I think what you were alluding to, correct me if I'm wrong, but the margin at the skull base is obviously quite tricky. And then the second aspect was that we had no facial nerve stump available for reconstruction. So the surgical team elected to do a mastoidectomy at that point to identify the facial nerve, and then sent the mastoid tip as a superior margin together with drilling down the tympanic bone. The plastic surgeons then reconstructed with a sural nerve, and they had 2 sural nerve branches, and kept it as upper and lower, so that they had separate innervation, and then attached that to each one to multiple distal facial nerve branches. It's just a video of the plastic surgeon suturing the perineum, but I think for time I'll go through that, I'll go past that. And then, so basically post-op, our plan at this point, we are still awaiting histology. Just thoughts on what the possible differential diagnosis may be. I don't know if I can put that out to the floor. Am I still connected?
Hello, this is Kenneth here from Accra. Did you tell us anything about the intra-op findings, what the tissue looked like, and the rest?
I wasn't intra-op myself. I'd have to ask the surgeon involved. There wasn't particular note of that. It was a firm tumor. Yeah.
So this is Busrak Getachew from Ethiopia. Are you hearing me?
I'm hearing you.
And according to our cases, the early perineal spread in this specific patient, so the patient is presented with a short time story with a facial nerve palsy. So I can say that this might be adenocystic carcinoma of the parotid, but it's very less frequent than any other parotid malignancy or salivary gland malignancy. So I would go for adenocystic carcinoma of the parotid.
Yeah, I'm not sure if there are any other comments, so I'll carry on. So yes, I think a carcinoma pleomorphic adenoma would be very high on the differential, given obviously the histology and the FNA. Otherwise, it would probably be about 3rd or 4th on the list. But otherwise, the usual suspects: mucoepidermoid, adenoid cystic carcinoma with the early involvement of the facial nerve, I think, is high on that list, and otherwise your actinic cells or adenocarcinomas. Then there's just a couple of other questions on or attributes. I'm not sure if we have time for, but I thought just to mention briefly when one would consider a neck dissection in an end-node neck for parotid, and as I have it, people consider a tumor basically a T3, so tumor more than 4 centimeters or extraparenchymal spread, and then all of the high-grade histologies. Yeah, and then after that, I mean, the next thing that I'll show, if anybody is interested, I'll just whiz through it, but it's pretty much in the time of COVID and the mastoidectomy surgery. As everybody's saying, I think we need to try and be as innovative as possible to protect ourselves and our staff. So what we've been doing is initially started by draping, instead of draping the microscope, we draped from the microscope over the patient. But we found that the plastic from the drape was very thin and it kept falling into our field. So Dr. Mervyn has actually used a slightly thicker piece of plastic that was sterilized and drapes it from the microscope itself by cutting a hole in the middle and create a tent. So you basically put that over the microscope itself, and that thicker plastic stays in place a bit better without collapsing into your field. Obviously, it's not an airtight seal, so normal PPE with N95s need to be used, but it does offer protection to prevent spatter. Thank you.
Thanks, Sean. Are there any comments, Prof, or from anyone else, just before we move on to the next presentation?
Yeah, Sean, just two comments. The one is that I would still have been loath to do such radical surgery without histology, because what if you, for instance, dealing with a lymphoma? I mean, that would be a non-surgical treatment. That's the one issue. And the other issue is you mentioned the indications for neck dissection, but just remember in the N0 neck with salivary gland tumors, this patient, if he had no neck nodes or she had no neck nodes, that the patient would require radiation anyway, and we know that radiation
is as effective.
As in surgery. So don't forget about the option of giving radiation to the N0 neck.
Okay, thanks, Prof. For the sake of time, we're just going to move on to our last presentation, just to fit them all in. Balkis, are you ready?
Yes.
Okay.
Okay, it's a quick case. My name is Balkis El Falah at UCT. So this case was seen before COVID-19 era. He's a 72-year-old male presented with 6 months history of right nasal obstruction with hyposmia and persistent auricular mucoid rhinorrhea. He had no epistaxis, no headache, no visual disturbance, no history of trauma, no constitutional symptoms, and no otological symptoms. So he was only hypertensive on well-controlled medication, and on his examination on the nasal cavity on the right, he had a big fleshy mass filling the whole nasal cavity, which was also difficult to assess the origin. And on the left nasal cavity was clear towards the posterior nasal space. He had no neck nodes, and the rest of his ENT exam was normal, and all his cranial nerves were intact. So we proceeded to do a biopsy under local anesthesia, and also he had a CT scan. So I just want maybe ask for some differentials based on the CT scan finding.
Bukle, do you want to comment?
Yeah, sure. So the CT scan shows a unilateral nasal mass. It's filling up the nasal cavity and the maxillary sinus, and I think there's widening of the osteomeatal complex on that affected side. There isn't any bony erosion of lamina or the hard palate. So, so this could be a benign lesion. So I would be concerned about things like an inverting papilloma, but because of his age and it's been 6 months, it could also be malignancy. So either a squamous cell carcinoma or a lymphoma or any other malignancy, really, whether epithelial or coming from soft tissue. But those would be my main concerns.
Okay, thanks, Bukle. Yeah, it's true what you mentioned. So on his biopsy, he had a confirmed inverted papilloma with no evidence of dysplasia. So we proceeded with endoscopic right median maxillectomy and SPA ligation, and he's on regular follow-up. So I just want to raise some highlights about the risk of malignancy with inverted papilloma and HPV relation, the period of follow-up for these patients, and then what to do with the hyperosteosis area on the CT scan and the lacrimal sac as well. So from what I read, the risk of malignancy is between 7 to 10%, and it's mostly with HPV 16 and 18. Regarding the follow-up period, some they advocate follow-up for only 5 years, but others they will follow up these patients lifelong. Regarding the hyperosteosis, that it needs to be drilled out because it's most likely to be the origin of the tumor. And then for the lacrimal sac, we also need to excise it because sometimes the tumor can get behind the sac. Thank you.
Thanks, Balkis. Are there any comments from the consultants?
Perhaps ask Darlene to comment.
Hi, thanks, Balkis. It was a good presentation. I think what's important with the inverting papillomas, just right from the beginning, is to decide whether you need an MRI scan or not. And I mean, the only indication for doing an MRI scan, I mean, we know in South Africa and the rest of Africa, it's not always possible to get a scan easily. But it does help you decide what approach you want to take. So, for instance, if you have tumor originating from the lateral wall of the maxillary sinus or even the anterior wall, it's quite difficult. It's more difficult to get that out than, say, a sphenoid pacification or involvement, just because you need better access to that lateral and anterior wall. So what we do is an endoscopic Denker's approach, making an incision on the anterior aspect of the inferior turbinate or on the piriform aperture, and that gives you, and then you can take the whole anterior wall away, so that you can really expose the whole lateral aspect and also get to that anterior aspect, which you can't get to with a Caldwell-Luck. If you do a Caldwell-Luck you really can't, I mean, you remove some of that wall, but you still can't see around the corner if you go through that antrostomy site. So the MRI helps you to plan your surgery. So if you see opacification on the CT scan, then the MRI will show you whether it's fluid due to obstructed osteomeatal complex and the maxillary sinus being obstructed and just fluid, or whether there's actually tumor originating from that area. On that scan, we also saw some bony erosion, I think, in the floor of that maxillary sinus, and that would make you worried that there might be some invasive or a squamous cell carcinoma as well. So that changes your management a little bit. You know, if you've got a squamous cell carcinoma with bony erosion, and then you might consider kind of an open approach. Also the frontal sinus, if you've got my findings anecdotally, if you have inverting papilloma originating from the frontal sinus, it's often a much more aggressive lesion. And the patients that I have had, you often find that there's a higher risk in my patients that you might miss a squamous cell carcinoma there. So you have to be very aggressive with those frontal sinus lesions and actually do a full endoscopic Lothrop. Very important that you have to get all tumor out. And then very close follow-up after that. So, you know, I see patients 1 week, 6 weeks, and then 3 monthly for the first year. And then I might make it 6 monthly for the second year, and then yearly follow-up for life. And in the past, I always said about 15 years. But we now know that you should follow patients up for life. You know, you can even after more than 50 years get a recurrence in that site. I don't know if there's any specific questions.
Well, Darlene, could I just ask you to comment, you know, if you don't have endoscopic expertise, and the treatment would have been a medial maxillectomy, I mean, classically, I mean, that was the way we used to treat them. But given the understanding you have now from endoscopic surgery, where you don't necessarily take the bone away around these inverting papillomas, would you advocate, if you're in a center where you don't have endoscopic expertise, that be more conservative and you simply scrape, you know, you do an open approach and you do a Caldwell Luck in this case and take down the medial wall of the maxilla, but that you quite conservative in terms of how you manage the bone, the bony component? If you had to retrofit, you know, what you do endoscopically to the open approaches.
Yeah, so I mean, when I started off, certainly, I mean, I've only started doing the endoscopic Denkers approach probably in the last 2 or 3 years. So, I mean, and I use the Caldwell Luck a lot. So I think, you know, if you have tumor that's in the maxillary side, so if you do an open approach, I think it's important to still scrape the bone clear, you know, if you can drill it. But often you see that once, the important thing is to do a submucosal resection. So if you do that submucosal resection, you often get an idea that that bone, or even the mucosa is not involved, and the bone looks clear. Then, you know, just using a straight curette, you can curette around the corners. And then something that, you know, I spoke to Weizke Fokens and Valerie Lund last year, and what they do, you know, those corners that you just can't get to, is use a suction diathermy, and really just diathermy the mucosa on the bone and make sure that you've got all this, get into all those little crevices, you know. So those are all tricks that you can use if you don't have access to an endoscope. I don't know if that answers your question, but
That's perfect. Thank you.
Are there any last questions or closing comments before we end? If that's all, thanks to all the presenters. Just to remind everyone, I've put the link up for the survey if you haven't completed the survey. Today we've had a record of 81 participants, which is great. Our next meeting will be on Wednesday at 1 o'clock, which will have an academic presentation. We're also going to start recording these sessions and upload them onto a website, but we'll give you details of that perhaps during the course of the next few weeks. So I'm going to close the meeting, and we'll see you guys on Wednesday. Thanks.